It's time for our next edition of National Journal Club, and I am super excited about this topic. Just one announcement, just to remind all the fellowship programs and everyone out there that submissions for the 2022 ACMT ASM Annual Scientific Meeting is coming up, and the submission deadline for abstracts will be November 15th. So get your projects organized and fired up and get ready to go. So this next journal club will be presented by our folks at the Harvard Medical Toxicology Program. I love the title. It's on shaky ground, predicting seizures in bupropion toxicity. Before I kick it over to the group, just a reminder, if you're out there on the Twitter sphere, use the hashtag ACMTNJC. And then also we will break between articles to entertain comments. We've got 5 articles today, so we'll try to keep things moving. And with that, I would like to kick it over to Dr. Michelle Burns to introduce her team. Thanks again, and take it away.
Very good. I'm Michelle Burns, and I am the Fellowship Director here in Boston. I'm pleased to be presenting today with our co-fellows, Michael Simpson, James Watson, and Jim Whitledge. And we are very happy that everyone's here to join us. So good afternoon to those folks on the East Coast, and good morning to everyone else who lives west of the Commonwealth. Our program is based here in Boston, and we have 3 training sites where we see our pediatric patients who are at, just one second, who are at Boston Children's Hospital. And then we see our adult patients at the Beth Israel Deaconess Medical Center and also the Brigham and Women's Hospital. Throughout our journal clubs, we obviously are discussing the literature, but we do want to mention some TOTS teaching factoids. Starting with bupropion. What's its mechanism of action? We know that it inhibits the reuptake of both dopamine and norepinephrine. And with respect to Tmax, which is the amount of time that a drug is present at its maximum serum concentration, this varies between the different formulations, but it's important to note that these are pharmacokinetic profiles at therapeutic dosing. So the IR is the immediate release. It's typically taken 3 times a day and is available in a 75 and 100 milligram tablet. The SR, or sustained release, is taken twice a day and is available in a 100 and 150 milligram formulation. And then the XL, or the extended release, it only needs to be taken once per day and is available as a 150 milligram or 300 milligram pill. The elimination half-life at therapeutic dosing is 20 hours for bupropion, and then the metabolite hydroxybupropion has an elimination half-life of 24 hours. And so what do our references say about how long we should monitor our bupropion patients? And so Goldfrank's and Olson's both recommend 24 hours, as does UpToDate, where it says that it's advisable to admit these patients and watch them for 24 hours. And so the articles we will be reviewing today include the one by Dr. Starr and Klein Schwartz, Incidence and Onset of Delayed Seizures After Overdose, published in 2009. I will be reviewing both the Buehler and Offerman pediatric papers published in 2010 and 2020. And then James Watson will talk about the Offerman recent paper with some of the crew in Arizona and California, bupropion-associated seizures in ClinTox 2020. And then we will end with our junior fellow, Jim Whitledge, who will be talking about the Ryan Prakasing paper just published a couple of months ago in ClinTox. So just to start it off, let's start thinking about how long we're going to observe our asymptomatic bupropion ingestions. And so we've got 4 choices here: 8 hours, 12 hours, 18 hours, and 24 hours. And so Steve, we'll ask your assistance with the poll.
All right, let's open up the poll right now. Can you folks see that? How long are you observing asymptomatic bupropion ingestions? There we go. I'll give it a couple more seconds. All right, why don't we end it there? And Is that showing up there? So we have, in case you can't see it, we have 10% 8 hours, 18% 12 hours, 11% are 18 hours, and 61% are 24 hours.
Very interesting. So, hello guys. I'm Michael Simpson. I'm one of the first year Tox Fellows here, and I'm going to be presenting the incidence and onset of delayed seizures after overdoses of extended release bupropion by Paul Starr et al. In the American Journal of Emergency Medicine, 2007. So a little bit of background. Bupropion was introduced to the market in 1985 as a treatment for depression, weight loss, smoking cessation. It was briefly removed due to concerns for seizures and then reintroduced a few years later after it was found that the incidence of seizures was markedly reduced if you kept the dosage under 450 milligrams a day. Then over the next 10 years or so, a few things happened. The XL formulation was approved, and there were some studies done on the IR and the SR formulations trying to characterize the incidence and the time of onset of seizures in patients who overdose on those formulations. But as of 2007, when the study was written, there were no studies looking at the onset of seizure activity specifically in the XL formulation. And that's really what this paper set out to do, is to characterize the timing of onset of any seizures and to look for any possible ways to predict who will and who won't have a seizure. This is just a graphic from the FDA review of bupropion, which can show that the incidence of seizures increases about tenfold when you go from a dose of 450 milligrams a day up to 600. So this study was a mixed observational study with both retrospective and prospective cases taken from 5 different poison centers across the country over a 2-year period from 2005 to 2007. And they included specifically acute ingestions of the XL formulation of bupropion in adults of at least 600 milligrams and children of at least 4 milligrams per kilogram. All the patients had to be observed for at least 24 hours post-ingestion, and they had to have known outcomes. And they excluded essentially anyone with a known confounding reason to be either more or less likely to have a seizure. So anyone who either co-ingested or was prescribed pro or anticonvulsant medications, anyone who was known to be at risk for withdrawal seizures, and anyone that tested positive for cocaine or benzos. And they looked specifically for the onset time of any seizures. They looked at some other signs of bupropion toxicity, specifically these mentioned over here in this table: agitation, tremors, hallucinations, and tachycardia. And they compared the incidence of those in seizure patients and patients who did not have a seizure. And they tried to identify the test characteristics of using those other clinical effects as a tool for predicting who will have a seizure. And then they looked at the NPDS outcome categories of no effect, minor, moderate, major effects, and death. They reviewed about 400 cases. They included 117. The vast majority, about 83%, were single substance bupropion only ingestions. The demographics were about 60-40 female, and there were very few children. There was only 4 patients under 13 years old in this study. The mean adult dose of bupropion was 4.3 grams, and the mean pediatric dose ingested was 35.6 milligrams per kilogram. And 31.6% of patients had a seizure at some point. The onset of the initial seizure occurred as early as half an hour after ingestion, up to as late as 24 hours after ingestion. The majority of those occurred in the first 8 hours. And then you can see they kind of taper off to where there was one patient that had an initial seizure 24 hours after ingestion. They did find a single death. It was a 16-month-old with a rather large ingestion who had multiple seizures and then went into VFib arrest. They did find that larger doses were more likely to be found in patients that had a seizure, but there was no obvious relationship between the dose ingested and the timing of the initial seizure. And when they looked at the other clinical effects, they found that tachycardia, agitation, and tremors were all more likely to be seen in patients that did have a seizure. Hallucinations were not. And even though in general those things were more common, there were still 17 patients that seized without having any other neurological effects. And there were 3 patients that seized without ever even being tachycardic. They also looked at GI decontamination, which was mostly charcoal and whole bowel irrigation, and found that doing GI decon did not appear to reduce the incidence of seizures. Of the other clinical effects, tachycardia was by far the one with the best test characteristics, with a sensitivity of 91% and a negative predictive value of 92.9%. The sensitivity of the other findings drops off pretty dramatically with the sensitivities of the 20s and 18. And then there's some other related clinical effects, less specific things like nausea, vomiting, confusion, that, as you can see here, are very non-specific and not necessarily predictive of seizures. So I think from all of this, the authors conclude that it's possible for a patient to have an initial seizure as far out as 24 hours from ingestion. And while ingesting a higher dose and having these other clinical effects, especially tachycardia, is suggestive of, going on to have seizure activity, there's nothing that's really perfect or great at predicting who's going to have a seizure. And so they end up recommending that all patients who have overdoses of bupropion XL should be observed for 24 hours from the time of ingestion. And I want to talk a little bit about this one patient that seized at 24 hours. Because I think, looking at the recommendations from Olson's and Goldfrank's and UpToDate that we kind of touched on briefly, I think this single patient who seized at 24 hours has had a pretty profound impact on some of the things we recommend and the way we practice with these patients. And from reading the study itself, there's a lot of kind of unknowns about this patient's clinical course. We don't know necessarily the age of the patient, how much they ingested, or what kinds of symptoms, if any, they were having before the seizure. Now, fortunately, after making this slide, we were able to get in contact with the study authors, Dr. Starr and Kleinschwartz, who were able to actually find some details of this patient. And we now know that this patient that had a seizure at 24 hours was a 14-year-old young woman who ingested 3 grams of bupropion XL. It was an acute on chronic ingestion, and she had a single seizure at 24 hours. And the only clinical finding we know of that she had was tachycardia. We do not know whether tachycardia was present on arrival, whether it was present before the seizure, or when she developed it in particular. So I guess what I would like to maybe kick off the discussion with is, just from this paper in particular, how do you guys feel about these conclusions? Do you think that this is something that you guys are recommending? You guys agree with this, based on this presentation? How do you guys feel about the recommendation to observe these patients for 24 hours?
Great, thanks. That is a really fascinating paper and fascinating topic. We have some interesting comments in the chat. And I'm glad that you did speak to Dr. Kleinschwartz. I see that she wrote in observation time depends on formulation. And again, if you, Dr. Klein-Schwartz, if you'd like to unmute and weigh in, that would be great as well.
Sure. Again, what we do is usually for immediate release, we observe for about 8 hours. For the sustained release, meaning the SR product, around 12 hours, and for the XL, 24 hours. Again, it's always hard to know whether based on one case, and obviously a poison center case where we have information, but sometimes not all the information you want, that we're extending out to 24 hours for the XL, but I guess at this point, that's usually what we're recommending for that particular formulation. And I believe one of the other studies, I don't remember which one that is being discussed today, there was a patient who had a seizure at 19 and a half hours, and that was after presentation to the hospital with the XL formulation. So it's not after ingestion, but after presentation to the hospital. So I think these cases are maybe unusual, but it certainly is possible to have sort of late onset seizures with the XL product.
Great, thank you. That's really helpful. And I think these outliers definitely would have piqued all of our interest. Other interesting comments in the chat here about symptoms. Alex Sidlak from Pittsburgh about the serotonergic symptoms. That's also an interesting concept. Yeah, and you know, we have a lot of ground to cover, so we got 4 more articles. Why don't we keep moving and we will circle back to this and get more discussion.
Wonderful. Well, let me jump in for the pediatric cases now. I am pleased to present these 2 pediatric bupropion studies, the first of which is by Michael Buehler et al. From the North Carolina and Kentucky Poison Control Centers. The study utilized the National Poison Data System and examined children less than or equal to 6 years of age with unintentional pediatric bupropion ingestions from January 2000 to February 2008, and included only those cases followed to known outcome. One definition to be familiar with that was utilized throughout the paper is ANE, which is adverse neurological effect and includes single and multiple seizures, as well as status epilepticus or coma. Over 7,000 cases met inclusion criteria. There were no deaths. 1,143 cases were excluded because of multiple substances, and another 174 were included a suspect variable and thus underwent further review, resulting in a total of 5,964 cases for final analysis. Outcome groups were compared with using the two-tailed Fisher's exact and Mann-Whitney U test. And so a total of 4,557 or 76% of cases were managed at or sent to a healthcare facility. The most common clinical effects are reported here in Table 1. And as you can see, ANEs and seizures had occurrence rates of 1.5% and 1.4% respectively. A milligram per kilo dose was calculable in 76% of cases. The average amount for the no effect minor cases and moderate major effect cases were 13.8 milligrams per kilo and 38 milligrams per kilo respectively, and this difference was statistically significant. The cases where an ANE was reported had an average dose of 73.6 milligrams per kilo. Of note, activated charcoal was used in 50% of included cases, with 44% of cases receiving no gastric decontamination. The outcomes and percentages of ANEs with various reported milligrams per kilo exposure dosages are presented here in Table 3. And for cases when the dose was reported as unknown, these cases had most centers and toxicologists would believe to be an unacceptable rate of ANEs of 2.6%, thus suggesting the need for referral for all of these cases to a healthcare facility. However, the authors state that one should be able to make an informed decision about healthcare center referral when a dose calculation in milligrams per kilo is possible. Over 75% of the total cases were already at or were sent to a healthcare facility, but of these, about 1,400 of them had a reported exposure dose of less than 10 milligrams per kilo, an amount associated with a 1.4% rate of moderate to major outcomes, but a vanishingly small amount of ANEs, that is an N of 1. So further inspection of that 10 milligram per kilo group revealed that except for one case of ANE, and that was at a dose of 9.6 milligrams per kilo, they were all moderate outcomes. And the most common clinical effects were mild, including tachycardia, agitation, and some hallucinations and tremor. And should these develop, the patient could be easily referred to a healthcare facility. So the author's conclusions for a clinically significant amount for a hospital referral after reported pediatric bupropion ingestion should be 10 milligrams per kilogram. And further justification for this choice is the fact that it's an easily remembered amount, less recall error by a poison center specialist, and that the clinical effects in this dose range were mostly mild. The authors report that use of this dose as a triage guideline might result in 31% of cases that might have been historically referred in could then be managed at home. 1.5% of patients develop seizures or coma overall. And once the patient is referred, observation must be for several hours to ensure that they will not develop seizures. Based on the average time to seizures, an observation period of 8 hours from ingestion time was sufficient for over 2/3 of these patients. However, the maximum time until seizures developed was 14 hours. And if Dr. Bueller's on the line, we'll touch base with him at the next pause to ask him if the patient was symptomatic or not. And so our next study is one from the single tox service involving 20 hospitals in California, a tale of two populations. This was a retrospective observational cohort from the years 2011 to 2018. And the impetus for this study was the fact that the literature cited younger pediatric patients manifested clinical effects in only about 8% of cases, while adolescents developed symptoms in 46% of cases. So the ages were subdivided into those less than or equal to 12 years of age, and then those adolescents age 13 through 17 years. 80 unique pediatric cases were identified, and we are very pleased that one of our Boston Children's pediatric tox attendings, namely Katie O'Donnell, was the supervising editor for this paper. And so the primary outcomes included the presence of seizures, a delayed seizure, which was defined as greater than 6 hours after arrival to the hospital, and then the composite endpoint of seizure, hypotension, or endotracheal intubation. And composite endpoints take place when you combine the primary endpoints into one result, with the goal of increasing your statistical precision while decreasing your sample size, and then one can hopefully decrease the trial duration and subsequently study cost. And for the category variables, they were reported as proportions with 95% confidence intervals. And then the continuous variables were reported as medians with interquartile ranges. And then for the dichotomous variables, the relative risk were estimated with as odds ratios with 95% confidence intervals. Tachycardia was defined as per standard PALS definitions. So the overall characteristics of the ingestions are shown here in table 1. Non-adolescents accounted for 31 of the cases, where the remaining 49 were adolescents. Within the group of non-adolescents, the median age was 2.1 years, while the median age for adolescents was 15 years, and the teens were much more likely to be female with an odds ratio of 3.5. The majority of the ingested formulations were either the sustained release or the extended release XL preparation. The non-adolescents were much more likely to have unintentional ingestions, 100% versus 10.2%, with a p-value of less than 0.001. And the known time of ingestion, as well as the known ingestion quantity, was higher in the non-adolescent group. Not surprisingly, the median grams ingested was 1.5 grams for the adolescents and only 0.6 grams for the younger children. Univariate analysis of factors associated with seizures is shown here in table 2. Seizures occurred in 21 out of the 80 patients, or 26% of the time. Adolescents were much more likely to have a seizure than the non-adolescents, 41% versus 3.2, which is an odds ratio of 20. Seizures were more common in the XL preparation as compared with the sustained release or that extended release twice daily preparation, again, which is different than the XL preparation. And the reported odds ratio for bupropion formulation showed a 3.4-fold increase in seizure odds, moving from that immediate release to the sustained release to that XL preparation. Tachycardia was highly associated with seizures, as was the documentation of altered mental status, with odds ratios of 12.9 to 14.9 as shown here. Those pre-specified composite endpoint of any seizure, endotracheal intubation, or hypotension did not serve to capture any patients who were not already captured by the seizure endpoint. Lastly, and fortunately, none of the patients in either group died. The seizure-related findings are shown here in Table 3. Only one non-adolescent patient had a seizure, and this was a 2-year-old who ingested a 300 milligram XL preparation and seized at 5 hours. And then the pre-hospital seizures were more likely to occur in the adolescents as compared to the non-adolescents. Then a total of 12% of adolescents had seizures occurring before 2 hours of arrival. One patient did specifically have a seizure at 8.5 hours, and multiple seizures occurred in many of these, all of whom were adolescents. So the author's conclusions here included the fact that upon ED arrival, if either tachycardia or altered mental status are present, there's almost a 15-fold increased risk of seizures, as adolescent predictors are similar to adults. With respect to unintentional ingestions in the non-adolescent group, seizures were rare, and to be more precise, only 1 out of 31 children seized, and that was 5 hours after ingestion. And while this study did not address observation times per se, it did comment that only one adolescent patient seized, and that was the one who seized at 8.5 hours. They do document the limitations of the study, which included it was a retrospective one with a small sample size of 80 patients. No comprehensive tox screens were obtained to rule out co-ingestants, and there were no laboratory confirmation testing run to confirm the actual bupropion history. And so, Steve, why don't we pause now to see if folks have comments about any of these pediatric studies?
Great. So again, if you'd like to make a comment, either raise your hand or drop it in the chat. We'll be happy to acknowledge you. Michael Bueller, I see you're on the line. Did you want to make a comment about your paper?
No, I thought it was a really nice summary of the issue there. Just pointing out that one of the problems is, obviously poison center studies, but we went out of our way to really try to get around that as much as we could by questioning a number of cases that had data points that didn't match up. But yeah, I mean, it was a good summary of it. I mean, the 10 milligrams per kilogram threshold seemed to be picked up pretty well, acknowledging the fact that there was one patient that actually would have been missed by that. But, and it does kind of bring forward to the question of, if these children are going to have a delayed single seizure, is this and I'm not suggesting it, but is this the end of the world if this happened while they were being discharged or at home? If there's any specific ones, I'm trying to bring over the spreadsheet to take a look at, and it's taking a lot longer than I'd like.
Okay, well, thank you. Appreciate that. Yeah, and I guess that's kind of where we're heading in terms of a question is, how much risk, or is there a threshold at which we're, some of us are willing to take that. I also appreciate Rebecca Brucaleri's comment in the chat about the metabolite peaking at 12 hours, the hydroxybupropion, which is interesting. Like, I know that as a group we'll sometimes make decisions based on, I guess, theoretical metabolic effects. But again, it's also rolling the dice with pharmacogenetic variation and how different are patients. I'm not sure I know the answer there.
We also have the issue of people that are on the drug chronically of having far higher levels at steady state of the metabolites, which is, in addition to the time till peak, that's another problem.
Exactly. And yeah, thank you, Chuck McKay, for your comment. All right, anyone else wanted to weigh in? All right, why don't we keep moving along then?
All right. Hi, everyone. My name is James Watson. I'm the second-year toxicology fellow here at the Boston program. I'm really excited to be talking about this paper, bupropion-associated seizures following acute overdose, who develops late seizures, by Steve Offerman et al. I'm really excited about this. It's actually one of my favorite toxicology papers that I've read since starting fellowship. I think it's very interesting, asks a great question, and does a great job to address the question that it asks. Speaking of which, the question that this study is asking is, which bupropion ingestions are at risk for seizures after 8 hours? Or to quote directly from them, they want to identify clinical features that are associated with delayed seizures. I think we've heard over the first half of this journal club that there's certainly a risk of delayed seizures with bupropion ingestions, and specifically with the sustained and extended release. And that kind of raises the question, well, gosh, does every single one of these patients now need to be watched for a full 24 hours? As you can imagine, that's a huge burden on resources, as we've all experienced as we deal with these consults. And it's frequently a significant burden on the patient and the patient's family as well. And so do all of these patients really need 24 hours of observation, or can we find a couple of distinguishing features that help us to tease out who needs to be watched and who doesn't need to be watched for the full 24 hours? So the methods here, this was a 26 center retrospective cohort study, including 20 hospitals and an integrated Northern California health system, 5 hospitals covered by a toxicology service in and around the Los Angeles area, as well as a tertiary care toxicology referral center in Phoenix, Arizona. The patients in this study were all cared for by a consulting toxicologist. Poison control centers were not generally involved in the management of these patients. A couple of definitions that I think are important to note. The first is tachycardia was defined as a heart rate greater than 100 or age appropriate as per PALS. Marked tachycardia was greater than 20 beats per minute above the cutoff for tachycardia. Hypotension was defined as systolic less than 90. A delayed seizure, importantly, was defined as a seizure which occurred more than 8 hours after presentation to the hospital, not after time of ingestion, but after presentation to the healthcare setting. The diagnosis, the way these patients were found was via diagnosis, and that was pulled from the discharge diagnosis. And then it is worth noting, however, that pediatric hypotension is not defined and altered mental status is not defined either. The primary outcome was the incidence of seizures following bupropion overdose. And there are a variety of secondary outcomes that were followed as well, including characteristics of these ingestions, observed signs and symptoms, the timing of late seizures, use of mechanical ventilation, hospital admission, and death. Statistical analysis was done via stepwise logistic regression to identify predictors of seizures and delayed seizures. Moving to the results, they had 437 patients who were included in this study. The median age was 29 years old. 9.6% of all patients were pediatric patients. The majority, 63%, were female patients, and 78% were intentional ingestions. Interestingly, there is a high percentage of co-ingestions. Approximately 53% or 232 of the patients had co-ingestions, excluding alcohol. The formulation was predominantly either sustained or extended release, with 38% being sustained release, 56% being extended release, and only 4.7% being immediate release. I think this mirrors kind of primary care physicians' practice and not wanting to prescribe a thrice daily medication when a once or twice daily medication will do. The formulation was known in about 89% of the patients. The median time to presentation from ingestion to arrival in the emergency department was 105 minutes. And the median dose for these ingestions was 1.5 grams, with a range from 0.1 to 27 grams. There were about 39 intentional double dosers and an additional, I think, about 30 to 35 unintentional double dosers as well. The clinical characteristics of the 437, the majority had tachycardia and 40% had altered mental status. 15% required endotracheal intubation and 27.9% required seizures. That's consistent with other data in this area. Of the patients with tachycardia, about 50% had tachycardia, which was sustained for more than an hour. Excuse me. There were a handful of cardiac arrests, 5 cardiac arrests. Fortunately, there were no fatalities. All of these cardiac arrests did survive. Each cardiac arrest occurred in the pre-hospital setting, and 3 the patients had additional in-hospital cardiac arrests as well. 2 of the patients went on to VA ECMO, and 3 received intralipid. Overall, this was a moderately sick population with clearly some patients who are very sick. When we talk about seizures, they found that seizures were dose dependent as demonstrated by this figure. The median dose for those with a seizure was 3.75 grams with the interquartile range from 1.2 to 6.75 grams. And the median dose for those without a seizure was 1.2 grams with the interquartile range from 0.6 to 1.2 grams. Tachycardia and altered mental status were both predictive of seizures. On logistic regression, patients who were tachycardic had a 4.4 times increased odds of seizing, and patients with altered mental status had a 3.93 times increased odds of seizing. Interestingly, and probably not surprisingly, when you think mechanistically, ethanol co-ingestion did lower the risk of seizures, as did patients who were double dosed, as opposed to patients who did not just double up on their dose. Only 2 of the 75 total double dosers had a seizure, and both of those seizures were pre-hospital. And now when we focus in on the real meat, on delayed seizures, seizures which occurred more than 8 hours after arrival to the hospital, we had 8 such patients total. This is 6.6% of all seizures, and 1.8% of the entire cohort of 437 patients had a seizure after 8 hours of presentation. And so then back to our question is there anything we can use to predict upfront a priori that these seizures were going to occur in a delayed fashion? And so when you take a look at this, you can see that every single one of these 8 patients had either tachycardia or altered mental status when they arrived in the emergency department. None of them were asymptomatic. You'll note that all except for 1 were extended release, and the 8th was a sustained release. That sustained release had their seizure just a hair over that 8-hour mark. So that's worth noting as well. And then you can see that the doses when noted were all relatively high. And this came in a variety of ages, both pediatric and adult. There are some limitations to this study. The authors note that this is a retrospective study which introduces recording and reporting bias. They're depending on the electronic documentation of seizure time. It is unknown if any patients were discharged prior to 24 hours of observation. Theoretically, they could have been discharged, seized, at that time between discharge and 24 hours, and then presented to a different hospital, and that would not have been captured. There is no confirmatory testing. They depend on the reported narrative for diagnosing these patients with a bupropion ingestion. However, they comment that this is consistent with real-world emergency care, and I tend to agree with that. They additionally mention the inclusion of co-ingestions as a possible limitation, but again, that improves the external validity and is consistent with real-world emergency care. And so I tend to agree that I think that this is less of a limitation. A couple of things I would have liked to see. It would have been helpful if we had a little bit of a larger pediatric population. As mentioned, only about 9% of the patients were pediatric. Also, there's no definition of altered mental status. Could some mild restlessness be coded as altered mental status, or is altered mental status really something much more extreme and appreciable? And then the other thing is I don't have a clear list of all the variables which are included in their stepwise logistic regression. For example, we're going to hear a little bit about EKG intervals in their influence in predicting seizures. We don't know if those are included or not included. But overall, this was a large multi-center retrospective cohort looking at both intentional and unintentional bupropion ingestions. They found that seizures in a delayed fashion are rare, but do occur, and that those patients who have seizures late are symptomatic on arrival and have taken either sustained or extended release. This paper is especially strong in that we can get much more granular and precise data than we can with many of these large databases such as Toxic or NPDS, and we can identify temporality of symptoms. With that, I'd love to open it up to discussion.
Okay, great. Really interesting paper. I think, table 2 was particularly interesting. And again, folks, if you'd like to say weigh in, please raise your hand. We'll be happy to get you on the line. I do like Michael Tosa's point about the majority of those also had a co-ingestion of a drug that could also cause tachycardia. Not all, but that is also interesting. makes that much trickier to, to come up with a guideline, the outer limit of how long to watch them. I don't know if any of the authors are on the line. I didn't see anyone's name.
I'm on. It's Michelle.
Oh, hi, Michelle.
Hi,
Thanks.
Steve. I don't necessarily have anything to add really, though. I think it was really nice summary, and the paper was done to, I think, confirm our own impressions that asymptomatic patients don't have late seizures. And it did confirm that, we see a lot of bupropion, but I think that at least I'm comfortable if a patient has been completely asymptomatic, I don't necessarily wait for a full 24 hours. I was one of the poll takers who put 18 hours because I just don't think if a patient is completely asymptomatic that there may be some risk, but very, very, very low risk of a seizure, after 18 hours if they've never had symptoms.
Yeah, that makes a lot of sense. Respect the potential toxicity, but if they're asymptomatic, the evidence gets weaker, all the way out to 24. Great. Well, okay, thank you so much. This was definitely a useful paper. Any other comments from anyone else out there? All right, not seeing any hands. Why don't we move on to the last paper?
Dr. Levine is asking Dr. Axe to unmute him.
Okay, and Dr. Axe, actually, Dr. Levine is asking to be unmuted because he had one comment he wanted to make.
Absolutely. Okay, actually, I am not seeing you as Michael Levine.
He's saying that he's calling in.
Oh, he's calling. Okay. Does he know, who is he on the call-in list? Oh, do we have a number?
He is 818.
Okay, we got him. That sneaky 818 number. Actually, Michael, you can unmute yourself from our side.
Hey, could you guys hear me?
Yeah, welcome, Michael. Thank you.
Hey, thanks. Sorry for that. I think just kind of tagging along to what Michelle said, I think that one of the things that this paper looked at, and it kind of confirmed our things, and I'm actually even comfortable at 12 hours, even if it's an Excel prep. If you watch them a full 12 hours and they are totally asymptomatic, they've never had tachycardia, they've never had any altered mental status, and they look pristine, I just think the rate of seizures is so incredibly low that I'd be comfortable clearing them. One of the other comments about the intervals, one of the reasons we didn't include it is just there were only 8 patients that had late seizures, and to start adding more and more variables to the model just makes the model so unstable that we couldn't statistically do it.
Great. Great. No, thank you for that. And, I appreciate from, both you and Michelle and Michael and others just hearing from, the authors that have dug into this. And also Chuck McKay, I appreciate your comment about comfort and also just risk assessment. Like, how do we arrive at that? So I think everyone's opinion is really, really helpful. So thank you for that. Okay. I guess, Jim, are you up next? You want to keep it going?
Yes, I am up next. So hello, everyone. My name is Jim Whitledge, and I am one of the other first-year Boston Children's Medical Toxicology Fellows. And I will be talking about a paper by Tony Prakay, Rob Hendrickson, and the Toxic Consortium, among a group of other authors as well. This was published this past April, and it is entitled Factors Associated with Seizure Development After Bupropion Overdose, a review of the Toxicology Investigators Consortium. So first, a little bit of background. There are a number of signs and symptoms of bupropion toxicity, which we have already alluded to, including sinus tachycardia, agitation, QRS and QTC prolongation, and seizures. And the authors of this particular paper were interested in seizure risk in particular, which is reported to occur in 8 to 40% of overdose patients, depending upon what study one looks at. Because many of these seizures are delayed in onset, as we've been talking about, patients often end up being admitted to the hospital for prolonged monitoring up to 24 hours, and the authors were interested in identifying clinical features of overdose patients that could predict who would and would not seize after an overdose. So how is the study conducted? A retrospective review was conducted of data entered into the toxic registry between January 1st of 2014 and January 1st of 2017. 458 cases where bupropion was a primary toxic agent were initially identified. And out of these 458, 164 were excluded because there were additional primary agents ingested contributing to the patient's symptoms. However, patients with co-ingestion of secondary agents, which were deemed to be not contributing significantly to the symptoms, were not excluded from the study. There were 2 cases which were excluded because the bedside toxicologist felt the patient's signs and symptoms were likely unrelated to bupropion toxicity. And then last, 36 patients were excluded because they were either less than 13 years old or greater than 65 years old. And after all these exclusion criteria were applied, there were 256 patients left that were still in the study. Out of the 256 patients, 36% experienced a seizure and 64% did not. 52% were Caucasian, 11% were non-Caucasian, and race was unknown for 37%. 41% were ages 13 to 18, and then 59% were ages 19 to 65. 38% were male, 63% were female. In regards to the chronicity of ingestion, 70% were acute, 25% were acute on chronic, and then 5% were of chronic or unknown chronicity. 92% were intentional ingestions. So how is this data analyzed? Demographic characteristics, clinical signs, and features were compared between those patients who experienced a seizure and those who did not. Unadjusted odds ratios with 95% confidence intervals were calculated, which you can see in Table 2. QTC greater than 500, QRS greater than 120, tachycardia, which in this study was defined as heart rate greater than 140, hypotension, and age 13 to 18 were all associated with seizures. And strikingly, 47% of 13 to 18-year-olds seized, whereas 36% of adults had a seizure. Then multivariable logistic regression was used to calculate adjusted odds ratios between clinical features and seizures, which you can see in Table 3. After logistic regression, QTC greater than 500 and age 13 to 18 years were the only statistically significant characteristics that were associated with seizure. Tachycardia, which again was defined as a heart rate greater than 140, was borderline significant. Given that QTC greater than 500 was associated with seizure on logistic regression, the authors examined this potential relationship further. 160 of the 256 patients included in the study had reliable QTC values documented, and 57 of those had a seizure. The mean QTC of patients who seized was 482 milliseconds, with an interquartile range of 59, whereas the mean for patients who did not seize was 454, with an interquartile range of 43. And the difference between these two values was significant, but there was not a specific QTC cutoff value with sufficient sensitivity or specificity to predict seizure. And you can see this lack of a sufficiently sensitive and specific cutoff in Figure 3. The authors calculated an area under the receiver operating curve, which is a performance metric telling you how well a model can discriminate between positive and negative cases. In this particular example, patients who seize would be considered positive cases, and patients who don't seize would be considered negative cases. An AU-ROC of 0.67 was calculated, which is considered suboptimal performance. For your reference, a value of 0.5 equates to a coin flip. In other words, essentially there's no predictive value, and an AU-ROC greater than 0.8 would be considered excellent predictive performance. The authors had a few takeaways after analyzing this data. They observed a 36% prevalence of seizures, which was in line with prior reported rates of 80 to 40%. the association of tachycardia with a heart rate greater than 140 approached significance. Age 13 to 18 was significantly associated with seizure, and the seizure rate of 47% in the 13 to 18-year-old age group was higher than previously reported, which the authors potentially attributed to the high rate of intentional ingestion in this data set, which was 83%. This may have increased the average amount of bupropion ingested and therefore the severity of symptoms. QTC greater than 500 was significantly associated with seizure, but there was no QTC value that was sensitive or specific for seizure. And unlike some previous literature, agitation did not correlate significantly with seizure risk. The authors do mention some limitations associated with the toxic database. There's no timeline in toxic to temporarily relate seizure with potential seizure predictors, so one cannot definitively say when findings such as QTC prolongation, tachycardia, or agitation occurred in relation to the seizure, and therefore how helpful they would be in predicting seizure. Overdose amount is not regularly recorded, and toxic database patients are seen by a medical toxicologist in person, which likely results in selection bias towards a sicker patient subset. So our takeaway, 24-hour observation is resource intensive. Delayed seizures are possible after non-immediate release bupropion ingestion, with this being more likely to occur with XL compared to SR. Patients who are asymptomatic on arrival are unlikely to seize after 8 hours. However, there are exceptions to this. And finally, we must consider whether 24-hour observation is appropriate for asymptomatic bupropion ingestions. So we want to hear your opinions, but first for our resident and student learners, we did want to check for knowledge retention with a couple of questions. Here's our first question.
All right, there we go. I hope everyone can see the poll right now. All right, and we will end it. Can folks see that? We have 97% for the answer C.
Great. Now our next question. And C is correct.
All right, we've got enough there. So we have 66% for number 1 and 26% for number 2.
And the correct answer is 1, which is indeed bupropion. Number 2 is cathinone. Number 3 is amphetamine. And then number 4 is MDMA.
Well, one of my fellows, Mara Tweed, we call her the bupropion fellow because she's had more of those cases than anyone. She just said bupropion are prescription bath salts. I love that.
All right. So at this point, we would be interested to hear from the audience again. And again, the big questions that we have are what diagnostics or clinical features are people using to predict seizure? Do people tend to look at age, QTC, tachycardia, agitation, or is there something else? Are people basing their observation durations on the presence or absence of these features? And secondly, then to return to one of the big questions of the hour, how long would you observe an asymptomatic extended release overdose? 24 hours, 18 hours, 12 hours? We'd love to hear any other thoughts that people have as well.
Yeah, so I see we don't have a lot of people bombing up to the mic here. Oh, here we go. No, actually, yeah, no, really feel free to put your hands in. We're thinking we've heard a lot of good arguments for, 24 hours is definitely the outer limit of maximal safety, but without symptoms, it doesn't make a lot of sense, I think, to most of us, to go that far. Oh, and thank you so much for showing my lava lamp. I appreciate that. Yeah, just wondering any other thoughts from other folks. How about on the issue of how long to watch the asymptomatic patient? If people could just pop in the chat and just kind of give us, if you've got a working ballpark, that would be really helpful too. All right, 12 to 18. Rebecca's still doing 24 hours. And, I think this is what makes this is such a fabulous journal club, because, you can read the answer, bottom line answer in one of the textbooks, but, we've all had the opportunity to look at this literature, and we can see there's a lot of limitation to the literature. So 8 hours of asymptomatic for XL. So that's very interesting. Depending on co-ingestants, absolutely. It's not even a good antidepressant, Bruce. I find that very funny. I suggest that to a psychiatrist friend. And it was fascinating that they're not so aware of our toxicity problems. So that's interesting. San Francisco is 24. Indianapolis is 24. Michelle Heiger, 24. Okay, but I want to do, okay, 12 to 18, it's me. That's fabulous. If they're adding DXM to it, that's very interesting. And Zane, OHSU, they're not tacky fully. They said 6 hours for IR, 8R, they can go home. Okay, that's a very practical and I think reasonable conclusion too. Right, so 24 and 12 from Todd, great, excellent. All right, well, that's fantastic, thank you. Do you folks in Boston have any final wrap-up comments?
We just wanted to thank everyone very much for participating in
Great.
this informative discussion.
And Brett Roth just had a quick question. I don't know what you guys think about double dosing, keeping them home versus sending them in. Do you folks in Boston have an opinion on that?
Our referral threshold is usually greater than 450
Or 10 per kilo.
or 10 per kilo.
10 per kilo. Okay, great. All right, well, we are winding down, but again, I would like to thank you guys so much. Fellows Michael Simpson, James Watson, Jim Whitledge, and Program Director Michelle Burns. Once again, this is a fantastic journal club from you folks. Thank you so much for doing this. Our next National Journal Club will be November 9th. It'll be presented by the Detroit program, led by Andrew King. So looking forward to that. So again, thanks everyone for joining us, and we will see you next time.